I am Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in the next session of No Thrombosis. So today we will be discussing vascular intervention and imaging, a series of live recorded case discussions live in box by the leading interventional cardiologists. So it gives me a pride, privilege, and honor to welcome our course director, Dr. M.S. Hiremat, sir. We all know sir is a director at Cath Lab at Ruby Hall Clinic, Pune in India. Sir has been a former president of CSI 2017 and convener for the National Interventional Council of India of CSI from 2004 to 2006. Sir had proctored many interventional cardiologists and has given live courses across the globe. Though sir is a coronary interventionalist at heart, he is equally adept at peripheral arteries interventions like leg, carotid, and aorta. And sir has been a part of some groundbreaking clinical trials. And more interestingly, sir has been a very, very keen interested in this low thrombosis and live inbox case. And last almost more than 2.5 years, every month we are discussing very interesting cases of intervention, coronary as well as peripheral intervention. At the same time, it gives me a privilege and honor to welcome our course moderator, Dr. A. Srinivas Kumar, sir. Sir is Senior Consultant Cardiologist and Director of Cardiology and Clinical Research at Apollo Hospital, Hyderabad. Sir has been a chairman of FACTS Professional Services, founder editor of National Medical Journal for the Postgraduate Medical Clinics of Osmania. He is a founder, course director for Advances Cardiovascular Solutions in India, ACVS India, TCT India, South Asia Conference. Sir has a special interest in TAVR, TAVI, and ASD, VSD, OCD, IVUS, and IFR. Sir has been a president of Cardiology Society of India of Andhra Pradesh chapter. And sir has been a principal and co-investigators for many, many clinical trials. Thank you, sir, being a part of this program. Always we love your interactions and your discussion points. Now, I would like to welcome our course moderator, Dr. Srujal Shah, sir. Sir is a director at Wayne's Clinic and visiting consultant at SIMS, Sal, Apollo, Sterling, and Sanjivani Hospital. Sir is interested in endovascular intervention, thoraco-abdominal aortic aneurysms, laparoscopic surgeries, and vascular interventions, and participated in various national and international conferences and workshops. He has many publications on his credit. Now, I would like to welcome our case presenter. Our first case presenter is Dr. Kavita Tyagi. So she is a consultant cardiologist at Dharmvira Heart Center and Sir Gangaram Hospital, New Delhi. She will be presenting a complex cath lab nightmares, a case study. Our second speaker is Dr. Shravan, CPS. He is a vascular and endovascular surgeon at Trinity Central Hospital and Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. He will be presenting on thrombo aspiration for DVT management, a safe and effective approach. So this would be our outline of the program. We will be having 2 case presentation followed by a discussion. With this short introduction, I will take a stop here, and I would Dr. Ravi, Mr. Ravi, is Dr. Kavita Tyagi joined?
Yes, sir. Yes, sir. Yes, sir. Madam is joining. So first case we will take from Dr. Shravan, sir.
So Dr. Shravan, would you like to go ahead with the first case? Sir,
yeah, no
is
problem.
It okay, sir? We will start with the second case, sir. Okay. Thank you, sir.
So just go ahead and share my screen. Is my screen visible?
Yes.
All right. So good evening, everybody. Thank you for Emcure for the opportunity to present a case amidst a senior faculty. So my case is a case of deep venous thrombosis where thromboaspiration was done. So going to the case directly, she is a 60-year-old female hypertensive with a known carcinoma of the left lung with malignant with a recent metastasis within 2 months to the lumbar spine. and she had to undergo kyphoplasty because there was a significant compression of the spinal nerves. And post kyphoplasty, there was good relief in her back pain, and the metastasis was also confirmed during the kyphoplasty because they did a biopsy, and because secondary to that, she was started on palliative chemotherapy. And when she came to me, she had a history of 1 week sudden onset left lower limb swelling. And on examination, it was a very tense, swollen left lower limb with a lot of restricted movement. And the dorsalis pedis and posterior tibial were not palpable, and only monophasic Doppler signals were present. No arterial components. And it was a case of phlegmasia alba on the way to go to a cerulear dolens. So this is a clinical picture. So this is a patient in prone. So that's why you can see the grossly swollen left thigh and the left leg. And you can see that because of the arterial component slowly setting in, the patient has already had a foot drop on the left side. And just a screenshot from the CT, you can see the size discrepancy, how big the leg is when you look at the left side diameter of the leg compared to the right. So a CT venogram was done. You can see there is no May-Thurner component. Let me just rewind that. So there was no May-Thurner component here. But as we come down, common iliac vein was open, but from the starting thrombotic occlusion, the vein, you can see that the vein is enlarged now, filled with a lot of thrombus, and some amount of heterogeneity near the common femoral vein, suggesting little chronic component there. But beneath that, again, still a lot of acute component. And of course, like I said, we can see the discrepancy in the size of the leg. If you notice, she also had an asymptomatic DVT on the other side. She has no history of any other DVT related or limb related complaints previously, but you can see that the other side superficial femoral vein is also occluded, but it is a completely chronic occlusion. So looking into this clinical picture, because of the patient is in phlegmasia, we have to relieve the venous the compression effect of the clot, and the options we have at hand are surgical thrombectomy, thrombolysis, or thromboaspiration. Now, surgical thrombectomy doesn't give great results. Thrombolysis we cannot do for her because she has a spinal met, and so the only other option we have left with is a thromboaspiration. So with that plan in mind, I screened her leg myself, and I could trace a short saphenous vein going clearly into the popliteal vein. So the patient in prone position, I took a short saphenous vein access under ultrasound guidance, and initial angiogram, you can see that just minimal flow seen and some venous collateral channels there. Doing the wire test, the wire just went like butter all the way to the common femoral vein. Just tasing the clot with some dye, you can see that clear tram track sign. So two things showing that it's an acute thrombus. One is the tram track sign, and the other is the the wire test where the wire just easily goes. But we did notice once it reaches the common femoral vein, the wire didn't go as easily as the rest of the popliteal and superficial femoral vein. So correlating the Doppler and the CT and the in-cath thing, we decided that we were expecting some kind of chronic component in the common femoral vein region. So we decided to go with a penumbra aspiration. So this is a Cat 8 X-Torque connected to our second generation penumbra pump. So gradually from each segment, the acute component was sucked out. So clearing the popliteal vein, then the superficial femoral vein, also taking the separator, which helps in two things. One, to declog the Cat 8 catheter, and also to break up the a big clot which is stuck to the catheter tip, so that there's a continuous aspiration going on instead of the catheter being stuck and we are forcing us to remove the catheter, flush it, and reintroduce it again. The video is little is in kind of a 2x or 3x. That way it looks like that. So we've reached the common femoral vein. You can see that the separator is not cleanly going as it did in the superficial femoral vein. The tip of the separator did get bent a little, but it did smoothly go up. So just after an initial single run, we took this shot. We have a path created, and also we can see two veins draining, one here and one to the left, and some clot in the common femoral vein suggesting the chronicity. So multiple more passes were done, and now you can see a better visualizing superficial femoral vein. Even the valves are being, the valve areas of the vein is, but there's significant flow reduction when we come near the common femoral vein. So this time, when trying to suck out the common femoral vein region, we couldn't use a separator, so I had to go bareback just with the Cat 8 and manually torquing it, trying to remove the thrombus load there. After removing this segment, did show us a lot of chronic clots when we sucked out the catheter, and you can see that the chronic clots are clearly seen in that region. But after a good clearance in that region, we decided it's time to just balloonplasty that common femoral vein region, because we have a good amount of flow now, and the on-table opinion was that let's angioplasty that. So taking an initial 8 balloon and then a 10 balloon and gradually increasing to a 12 balloon, the common femoral vein region was plastied. You can see that some amount of waste is there, and then good flow right from the sheath in the popliteal vein all across the superficial femoral vein, the common femoral to the iliac segment. So this is a picture of all the clots which we retrieved. You can see that these bright red cherry-like clots are all the acute component, but these more fibrous whitish kind of clots are all from the common femoral segment. Post-procedure, she is still on low molecular weight heparin, twice a day dosage. And after completion of 2 weeks, I'm planning to switch her over to apixaban full dose. Thank you.
So
Dr. Shah?
second moderator, Dr. Sujal Shah, is also joined.
Hi.
Yeah, he being a vascular surgeon, you want to comment first, sir?
Hi, good evening, dear all. First of all, sorry I joined late because of one patient. Shravan, very good case. You mentioned that it was phlegmasia cerulear dolens, right? And patient had foot drop.
It was alba, sir.
Alba.
Yes.
Patient had foot drop.
Alba, yeah.
So how long this procedure was done? 2 weeks back? When was it done?
It's around 10th day now, sir. Around 10th day now.
Okay. So and you are happy with the overall recovery, right?
Yeah. Day one, our limb girth came down by almost 7 centimeters.
Okay.
The tense leg became immediately soft, supple. Even before I could tell anything, when I met her the next day morning, she was extremely happy because she could even walk the previous day. She came to me on a wheelchair with a heavy leg, and now she could fold her leg herself. She could feel the softness in the leg. So there was a tremendous improvement within 12 hours.
Okay. So you mentioned that open venous thrombectomy doesn't give very good results. Have you ever seen somebody doing, or have you ever witnessed the results?
Sir, I have been part of a couple of cases only, but let's say even this case, even if you do a venous thrombectomy, you still have to address the chronic component in the common femoral vein.
Agree. Yeah.
So unless you're doing the thrombectomy in a cath lab in a hybrid setup, where you can do the thrombectomy, it's similar to our arterial. Nowadays, it's not enough just to do the embolectomy. You have to do embolectomy, take a check angiogram, see the way all the way to the foot. So even if it's a venous thrombectomy, the same rules would apply. Do a thrombectomy, see for the chronic component. Maybe if she had a May Turner, more a reason to, after the thrombectomy, to go out with the angioplasty and stenting and all.
Yeah.
So like previous time, there may be thrombectomy.
But anyway, Dr. Shah.
Sir, sorry?
Yeah, sorry, go ahead. No, go
Yeah,
ahead.
but
What do you think?
I would tell you, open venous thrombectomy also gives fantastic result. I have performed actually only once for a patient who was worse than this, and we got a very good result. And that case had won a best case, award in European Venous Forum. So the good thing
remember
there
that,
is you can actually compress all the. You can use the Ashmark bandage and squeeze out all the thrombus from the smaller venules also. In this particular patient, your decision was right because of the chronicity. But in acute DVT, very rarely you may have to, 1 out of 1,000 or 1 out of 2,000 patients, you may have to do when the patient comes to you late.
Yes, sir.
Otherwise, fantastic case and very good outcome, very good result.
Thank you. Thank you, sir. Thank
In
you.
general, Dr. Shah, if there's a percutaneous option, patients and we always prefer percutaneous option rather than doing surgery. That way also, I think because it's chronic, he decided for this suction. Acute, you would have did surgery, you're saying?
No, even acute CDT would be better than anything else. Thromboaspiration plus CDT is the choice. And in my in my hospital, we see almost daily 2 to 3 acute DVT and 3 to 4 chronic DVTs. We rarely do interventions. I used to do in 2011-12 when I passed out, but then gradually I reduced due to availability of very good medical management. Even iliofemoral DVTs, when you start early medical management and you give compression bandages or stocking, the outcome is very nice. We have not published or we have not got particular data, but clinical experience is quite good. So interventions we have reserved for those swellings where actually the swelling is quite tense and you have to convince patient for intervention.
That's what happened. Here it was about to threaten to get into drop and an arterial compression also happening. That's why I think the decision was correct only to do intervene.
Yeah.
Yes, sir.
I think compared to coming to the devices which are used for suction, I think you have 2 devices available. One is penumbra, other is angiojet.
Yeah.
Normally, penumbra is becoming more popular. Because it has a little more better results, but sometimes results are quite variable. I think it comes in 6 and 8 French. For venous, you use 8 French. For arterial, you use 6 French.
Yeah.
And then that only problem with that is a little expensive. That not only the device, that what we call that sucking thing in the front wire. What is that called as a separator?
The separator, sir.
Separator. That also costs
each is 1 lakh, sir.
That
each
is only challenge with this. And then, but sometimes we have tried when the patients were not able to afford, it goes on the regular thermo wire. So when the patient was not able to afford, we did try with some end-hole catheters, which you use in cath lab also, because as a desperate measure, sometimes it's not recommended, but that is expensive. So we did try with the only thing is it gets choked, that the tip gets clogged with the catheter clot. We need to take it out and again flush it, and that's what your advantage you were telling. Because of the separator, it doesn't get choked and you can suck more. And the other thing, for the sake of listeners, how do you know when to stop it? One is you can, once you got the result, you're happy, you do it. Other thing is any parameter like blood stops freely coming into the penumbra sucking device. That's again an evidence probably clot is enough sucked, and some people take 500 ml as a landmark because after that again patients becoming more anemic and hemodynamically unstable. There are some parameters, but you got the best result because the flow almost became normal. But many of the times, if it is chronic, you won't get such good results. A lot of residual thrombosis remains and the flow will not be established totally. So in that case, the other parameters and followed by again long-term heparin therapy and other things will be helpful in these patients. Recently, we had an experience where pulmonary thromboembolism patient also. We did suck because patient had some low platelet count with PTE, some strange combination. So we couldn't give too much of lysis. So we did suck. And on the regular wire, we used this suction device for sucking. For the catheter, we couldn't use the separator. We used a multipurpose end-hole catheter to suck in. Sometimes a desperate measure, human body is great, it appears. Even little flow is established, a lot of recovery happens. And the pressures improved once we sucked and the patient improved. The other type of device, angiojet, I did not have opportunity to use it, but the mechanism it is supposed to be sending fluid inside and then sucking, no? Did you have a chance to use that?
Yes, sir. Yes, sir. There's two balloons, and in between the two balloons, there's a rapid rheolytic thing going on, because there's a jet of saline plus or minus a thrombolytic fluid coming in. But the only thing with that is because of huge number of RBC breakdown, chances of kidney shutdown, acute renal failure, all that is there. So I've used it a couple of times, but my personal preference is a penumbra over an angiojet anytime, sir.
Hiramat sir, normally in coronaries also there was some data which came up with angiojet and all, but it is not very proved useful, no sir? Did you have a chance to use that in coronaries?
No, I mean, we have used something like that. I mean, basically aspiration, especially when it comes to veins, surgical bypass, and you have clots in that. I think aspiration as early as possible is the best way. If you wait too long, the vein is gone. So I would probably feel that under this setting where you expect a lot of thrombus, aspiration is a must, and different kind of devices are available for aspiration.
Yeah. During COVID times also, we were getting a lot of cases. We did use this device. One more advantage of this penumbra type is it's done faster, because in COVID times, angiojet, it takes about half an hour time for it to pump and then get the solution back and all that. This we used to do it relatively faster. So that was another advantage quoted with penumbra. And our hospital also has some stroke cases, acute stroke interventions being done.
Yes.
The company left the sucking device in the hospital. So sometimes a patient may not afford too much also, still we use and offer the benefit to these patients.
Yes, sir. Now, one thing good from penumbra is, sir, they are coming up in 12 French and 16 French devices are available in the US. Mm-hmm. And they also have something as a lightning system, sir, which is like intelligent suction. Here, our issue is we don't know sometimes whether we have engaged a clot or it's an open vessel causing the free flow. But the lightning has an inbuilt chip where it will automatically detect that we are in free flow, and it will automatically shut down the system, stop the suction. So according to the company guys, it should be available in the next 6 to 8 months in India. So once that comes, our blood loss will also be less, and because of a higher bore of 12 French or 16 French, our results will even more better and faster, I guess.
Yeah, but too much big French also could create trouble, vascular, other problems. But I think somewhere 10 to 12 should be optimal. If it is too higher, 16 also, sometimes it could create trouble. Anyway, good case and patient improved. That's the most important thing. But it's finally a malignancy and other problems will decide our fate now. And there is some data I was surprised to hear that low molecular heparin injection treatment in patients such in cancers actually proved a little more. Initially, it was confusing. It was more beneficial than using chemotherapy. The data said that it prevents some of spread of this metastasis and things like that. I think different mechanism. But low molecular heparin also reported to be beneficial in such patients with malignancy with where the clots happen. I think so.
Sure, sir.
Right. Okay, over to you. Any other comment, Dr. Shah, or shall we? The other doctor is ready now?
Yes, sir.
Shall we proceed to the next case, sir? Hiramat, sir?
Yes, please.
Okay. So we have Dr. Kavita Tyagi. She will be presenting our second case. So over to you, ma'am.
Yeah. So, good evening, everyone. Thank you so much for inviting me. And I'll be talking about a case of calcified stenosis angioplasty with the help of imaging and intravascular lithotripsy. Next. So, coming to my case, 65 years old male, hypertensive, not diabetic, and he had angina, which was increasing, rest angina in last few days. LVF is our normal and renal function is also normal. So this is angiogram. Please play again. So we could see that when LED was being shown a lot of calcium. So LCX angioplasty was done before. You can see nice flow in LCX. Next, please. And now coming to LED, as we have seen already. So we did also OCT. We did not have any limitations because kidney function is normal. So it is OCT pullback in LED. So we can see a lot of fibrofatty plaque and a lot of junk calcium, what you call as we can. So we know that this heavy chunk of calcium is not always amenable to the protein balloons we have with us. So if we see OCT analysis of this LED, this was the distal reference diameter. Then here we can see how much calcium. Then, and we can see that it is eccentric calcium. And this was the proximal reference diameter. Next, please. So strategic pre-treatment approach with OCT. We have to plan either direct stenting, or we do semi-compliant ballooning, or we do non-compliant or scoring balloon, or we do rotational atherectomy plus minus IVL. So we know that if the plaque is low calcific burden, lipid rich, with initial ballooning, we can go for stenting. And in patients with moderate calcific burden, to see whether calcium is deep, or in cases of neointimal hyperplasia, also we'll use the scoring balloon. When there's a high calcific burden, we'll see whether it is calcium nodule or superficial calcium. Depending on that, we will choose or we'll decide to go for rotational atherectomy, followed by IVL, or both together if required. I mean, sequential. So OCT-based calcium score, if we read, maximum calcium angle, less than 180, we give 0 points, more than 180, 2 points. Maximum calcium thickness, if more than 0.5, 1 point. And calcium length, more than 5 millimeter, 1 point. And total score becomes 0 to 4. Next, please. So we have seen nodule of the calcium. So we directly go for, after initial ballooning, we go for intravascular lithotripsy, 3.5 into 12 millimeter in size. So after doing this IVL lithotripsy, and we have seen the proximal and distal reference vessel diameter, and we have seen that there's a good healthy landing zone, proximal as well as distal. Next, please. So this is OCT pullback, again taken after IVL. So we'll appreciate now, I think. Yeah. So pre-IVL, we could see all these nodules and deep calcium. And this is post-IVL, wherein we see, because we know as IVL works through softening the calcium, so we can see it's the structure somehow fragments, and we can push it to the side, and stent approximation is better. That is how it works. So we can see the difference clearly. This is pre and this is post. Very nice picture indeed. So we take a drug-eluting stent from left main to LED. So this was the stenting, 2.5 into 33 millimeters. Next, please. So we are seeing the stent boost. We can see that at this point, stent needs some post-dilatation. So we again take up 3.5 to 15 non-compliant balloon, which makes it a little better. However, not to that great extent. Then we take NC track 4 into 8, which is little localized and but bigger balloon. So it makes it slightly better than this. And then again, we take a OCT pullback. Next, please. So after putting our stent, this is the OCT. So largely, we can see that the entire stent is well opposed. As we see, there is no dissection at the distal end of stent. In between, we are seeing some plaque prolapse maybe, but overall uniform placement of the stent and hardly any under deployment or at this point, because this was the branch over here. So if we see OCT after regulating the stent, here at this point, we could achieve 6.84 millimeter square area. And then, so at this point, we again do 4.5 into 8 millimeter optimization. And this was the final result. Very nicely placed stent and without any distal dissection, without anything in left main. So a few points we can consider, we should remember that transradial approach always, unless not possible. Glide sheath slender 7 French guide catheter. This always allows us to use any hardware we want. Rotablator, large size cutting balloon, or bifurcation if I want to do a double balloon or 2 stent strategy, or imaging devices or thromboaspiration catheter, whatever. So it always becomes so much feasible. Guide catheter support is obviously important. So we should always study angiofilms. If some confusion is there, then we can do CT angio as well. And imaging modalities, yes, nowadays, I mean, obviously everybody is using them very much, but we should not hesitate. We should justify their use, and we should use, especially in such lesions where it's a long lesion, it's a calcified lesion, it's LED, it's a proximal distal also, we have to see the landing zone, etc. If required, FFR, IFR to be done. And yes, guide wire is to be chosen with utmost care. And we should upgrade the guide wire whenever required, whenever we feel that it is not able to hold the balloon or it is not able to close the lesion or whatever. And never hesitate to use microcatheter or OTW balloon for support. Buddy wire technique should never be forgotten. We use it often. Using anchoring balloon or mother-child technique for getting access during guidezilla is always to be remembered. Going from smallest size balloon to achieve the best bed preparation with either angiosculpt, cutting balloon, rotablator, IBL cannot be overemphasized. Strategizing for a bifurcation is either a single stent or provisional stent or 2 stent strategy forms the crux of the interventional technique. Checking about whether this is a chip case or not is only the result you can make. Keeping a proper team with you is the mantra for the success. Thank you so much.
Hidamat sir, you want to go first?
Oh, you can go ahead.
Yeah. I think Omkar, you told us she's about to show some complication. We are eagerly waiting, and now she showed a calcified lesion. Anyway, case was good. How OCT helps in decision making, all that she presented. But initially, what we heard is you're going to show some interesting cath lab complication, madam. Anyway, this is a good case. You changed, I think, in the last moment. You got a good OCT case. That's why you wanted to change. Okay.
Actually, I was busy in my case, so I could not get this much time to sort that case out, and so I took it up.
No, anyway, no problem, because learning happens more in complications, and we can always learn from others' complications rather than we producing complications. So what you have shown is a good calcified lesion, how it has to be assessed by OCT, and you've shown those criteria and how usage of IVL balloon helps to crack the calcium, those things also. The latest Ultreon version of OCT, what you showed in the slides, the comparison pre and post, it's supposed to give it also for more user friendliness, and it helps us to decide how to do it. And you also showed us how to optimally post direct the stent, post-procedure. But one word of caution, if people are not using imaging, is these latest versions of stents are so good. If even without proper bed preparation, sometimes it is difficult to take NC balloon, IVL balloon, but these low-profile stents could go. Just because they went and you inflate it, and then the residual thing remains on the stent, and you land in trouble there. You don't know what to do then. Then off-label indication of IVL within the stent, all that starts. So that's why, as you said, shown proper bed preparation is very important, especially you have a deep calcium and long calcium. The usage of IVL balloon, sometimes what is also recommended is IVL produces just cracking in the calcium, and probably you need to take NC balloon again to open and increase the lumen area. And so that the cracked ones get separated and you get a better optimal area. And in some of the cases, not in this case where it's proximal LED, but suppose some vessels are diffusely diseased and small thin vessels, people are also trying just regulating balloon deployment once everything is cracked and opened out. Those are some of the things. But you did show some LCX procedure done before LED, is it?
Yes, sir.
So normally, whenever you have, just for learning sake, maybe it's a simple lesion, you thought you could tackle it easily before and do it. But generally, as a dictum, we tackle the toughest lesion first. And then if suppose the idea was, suppose anything happens, you're not able to tackle well, patient can get the benefit of surgery. Now, Hiramat sirs and most of us, dictionary, there is no surgery. So that's why you must have thought anyway you won't send for surgery. You must have tackled LCX. But by and large, LED needs to be tackled first before we go on to another lesion, unless there is a ACS type of lesion which is occurring because of LCX. Other very rarely is a very straightforward focal lesion. We want to fix it up, stabilize it. That may be one thing which went in your mind. To fix the LCX first, but by and large, the toughest lesion first and the difficult lesion first. And LED always gets a preference over other vessels unless there's some particular reason to do the other vessel like ACS and things like that. But overall, it is very good.
Sir, actually, angiographically, this LED was, other than the calcification part, it didn't look actually much complex because there was no bifurcation, there was no angulation, there was no tortuosity.
In that case also, you should do LED first because LED is always important. Anyway, it's all choice, but just for sake of learning for everybody, I'm just mentioning, LED always gets precedence and importance over other because 50%, 60% of my academy is supplied by that compared to other vessels. Also, sir, you are telling something, sir? Yeah.
I was also thinking that if you do the difficult vessel first, the material that you're opening up is getting into the more complex or more difficult vessel. And the same can be used on the
easier
lesion in the other vessel. I would probably feel that in terms of hardware also, save a lot if you do the more difficult vessel first and then go to the next one. Dr. Kavita, what about the stent start? I mean, whenever there is an ostial lesion in the LAD, many people now believe that the stent should start in the left main and go over to the LAD, and then you have circumflex side brain stent. I know that this is a very sort of much more difficult procedure compared to the way you did it. But would you like to now start thinking that instead of starting the stent exactly at the ostium, you can bring it back to left main? It would probably be a better idea.
So actually, imaging is something which really helps in these difficult decision-making things. So OCT showed, and concepts are there that polygon of confluence should be tackled with the stent. People are of the opinion that if you're putting a stent in LED ostium, then you need to cover it up to left main, at least polygon of confluence. But yes, if imaging, I think imaging shows that clear cut it is a healthy area, then maybe then we can very well pinpoint, especially these giant stents, since their marker and stat is on the same point. So I think maybe we feel that sometimes we can be actually precisely put the stent wherever we want. So that is how, if we are tackling the ostial LED, then we certainly take help of imaging. we make sure that this is LED ostium is disease free. So then only we decide. Otherwise, we always come to left main, and then concept we see that if LCX ostium is we feel it is pains, then we put a wire across and we try to open the at least studs with minimal balloon of 2 mm. That is how we practice in our center.
But as imaging did show much of disease there, and left main was free from disease distally, and that's how you chose this path, I think. If the distal left main also had some disease, which is generally thought of, normally it is said that angiographically, though it doesn't look, but imaging wise, if you do, you could have disease. But here you had a very big area of left main which is totally free from disease. I think that's how you decided more for LED. Even if LED is totally, left main is totally free from disease, and you have generally there is a 1 mm or 2 mm stump left in the proximal LED where you can land the stent easily, then probably we would follow this approach. And LCX, I feel always is difficult, especially osteal LCX, difficult animal to conquer. Unless it is absolutely essential, don't touch it. Because if you do some procedure, the patients tend to come back most of the time because restenosis in LCX ostium. So I think if you have a reasonable landing zone, your approach is also okay. Other participant, Dr. Shravan is there. Any comments, Shravan?
Sir, so what about this practice of when you come to at least polygon of confluence? I mean, you come across the LCX stud, and if you see LCX ostium is completely healthy, at least angiographically, then do you recross it and do you open the studs, or you leave it like that? Because people vary in their opinions on tackling the LCX ostium, wherein the stent has gone across LCX ostium.
Yeah, people did OCTs, and when the stent studs across are there in the LCX ostium, people said bridge restenosis and things like that are happening. But by and large, even if for that reason you want to open up the strut, do a very low pressure cuddle, like what you call this, like loving in inflation, not very high pressure, just to separate the struts. But if you give very high pressure inflations, then LCX osteums tend to get into trouble. So unless it is absolutely essential, avoid too much high pressure inflations to the LCX ostium. That's how I follow generally. I don't know what sir says.
The idea is basically to get the strut out.
Out with a small low pressure inflation, but not very high pressure damaging the LCX ostium again. So that is also, people are saying after OCT, this path is followed. But I feel even if something is there, if you are not able to do OCT, if angiographically, if it is totally looking normal, flow is actually, in fact, even if angiographically there's pinching also, if you do FFR, it comes negative because most of the times it will plaque shift. So unless it is essential, generally we avoid doing kissings. But sometimes the flow is less compromised, and then you have no choice.
I would also feel, Dr. Srinivas, that if you are doing a kiss, the circumflex on the angiogram is looking quite nice at the mouth. Don't get the balloon deep into circumflex. Yes. I think the balloon should be just looking at circumflex, and that is how you do a kiss at the distality of the vein.
Yes.
Sir, no, but what I mean that we just suppose LCX is quite roomy, and we just take 2 mm balloon, maybe 3/4 of the size or half of the size of LCX size, and we just, small size, maybe 2 into 8, and we just open the studs, and that's it. Are you talking of this procedure also doing simultaneous kissing, ballooning to LED also? That is how it is. But what we have done in few cases, that we have just opened the studs, and that's it. We have not done the simultaneous balloon inflation.
You have to be absolutely careful not to damage any stent struts in the LED if you're doing that. So small balloon without much of disturbing the main vessel, again doing the pot finally is important, not to distort the main vessel stent and the stent in the LED.
Yeah, so, if you put only a balloon in the side branch and not put a balloon in the main branch, it is shown that the side branch balloon can draw the stent from the roof of the vessel down. So it's not a good idea that main branch doesn't have a balloon when you're doing a balloon to the side branch. So I would feel that it has to be a kiss and never a single balloon to the side branch.
But don't protrude too much into LCX, just put it the ostium. That's what sir is telling. Yeah, Shravan, you are telling something?
Yes, sir. I have a question actually regarding the IVL. Because I hear some things from my cardiology colleagues that there are few case reports that post IVL there's a perforation at the IVL site, and it's becoming more common. Is there any specific reason, or it is just an bit somebody's noticed it?
Any technology will have some downside of it. You let us think positive about it. It has made
no. I just want to
quite easy and technically less demanding. Anybody who can do balloon angioplasty is able to tackle calcium with IVL, provided you produce some minimum lumen to take that balloon there. But if you're not careful on the sizing, right? If you take a 2.5 vessel, put a 3 mm IVL, there's more chance of getting into trouble, is it not? The size always needs to be under considered. So if you should be carefully select, if at all you have a doubt, select a quarter size less one, but not oversize. Because if you're oversizing, that's where you can lead into trouble. Other thing, what happens is a calcium spicules, sometimes they protrude inside and the balloons tend to get ruptured. And the ruptured balloon with high pressures, if you're doing it, that also tends to damage endothelium and produce problems, not only the IVL per se. So these are some of the things we come across, but both operator and patient has to be lucky to not to get into trouble. So always keep patient safety in point and don't overdo things. And always keep a watch on the fluoro when you're inflating. The indentation, whatever comes there, once it goes off, then probably that's where I think you can come down. The other tips to avoid balloon ruptures is we tend to immediately deflate it. What is recommended is at 4 atmospheres, once you inflate it, you notice the indentation, then our general tendency for NC balloons is keep on inflating till it opens. Here, that is not required. The shocks which produce up to, supposed to be producing 30 to 50 atmospheres when that shock happens. And that will produce the trouble, not your inflations. So, but after stopping it, again, continue pressing that button till that meter becomes green on the machine. One, after it becomes green, then you stop the pressing button. Then other important thing is you take it up to 6 atmospheres again, so that the balloon, if you directly deflate it also, sometimes these shocks are troubling the balloon and the balloon ruptures are happening and leading to troubles. But now with the better latest generation version of IVL balloon with 2 layers of it, the ruptures are less common. So complications are also less common. It had more problems with the first generation where the only 1 layer balloon was there. These are some of the precautions to avoid trouble, but always there's a downside to any technology. Use it always keeping patients' safety in priority. But I would say it has definitely simplified the way we do tackling. Because rotablation was technically more challenging, demanding. Not many people could follow it. Whereas now, this is a more simpler way to do it, provided you do it right.
Yes, sir. So is there any case where actually post an IVL, you choose not to stent, or it is always a stent post an IVL?
One of the area what we thought recently, we started doing orbital atherectomy also. LCX ostium, only isolated osteal LCX. It's a difficult thing for us to conquer yet. So whatever we were doing, we were trying to get the restenosis back at LCX ostium. And orbital atherectomy is chipping off, shaving off all the calcium. And we did imaging, and then areas are also quite good. There, of late, if you put a stent there, there could be some compromise in the LAD or left main. So we use a drug-eluting balloon, the Magic Touch balloon after that, and then avoided stent. So there are some particular things where, and a long diffuse nature, where you can't put a long stents also. Sometimes we might avoid stent, and Montano Colombo is proposing this concept where you treat the lesion, dilate it well, and he goes to the extent of saying, even if the significant dissections also, as long as the difference of gradient is not much, you can still leave it and dissections heal off after the drug-eluting balloon. But LCX ostium is one area, I think, where we could try this strategy, where you chip off, shave off with atherectomy and then probably give a drug-eluting balloon. Because putting a stent there, again becomes a very complicated. We have to work like a bifurcation procedure, be ready to tackle if LAD gets into trouble and all that. So that's some of the places immediately when you think of it happening. But actually stents have proven beyond doubt. So if you're not putting a stent, You have to have a definite reason for not doing it.
Okay. Thank you, sir. I'll remember that and extrapolate that for my peripheral cases.
I think the mid of the mid LED is more superficial. So, and obviously smaller in size in comparison to proximal. So I think we can be a little extra cautious when we do such calcific lesions. So I think we are extra careful in.
Yeah, sizing you are telling, no, madam.
Mid-LED,
You have
mid-LED.
to take the size of the distal vessel into consideration. That's what it's telling. And always keep that in mind. Pressure is one aspect and the size of the balloon is the other aspect. Even the OPN balloons also. This is very important to keep in mind. The size of the balloon should be kept limited. If you higher pressure, you can go on a undersized balloon. But if you take a bigger size balloon, go high pressure, that's a dangerous combination to develop perforation. Any other comments, sir?
IVL balloon, I think, I believe in Europe it's very popular in the peripheries, not so much in coronary, but periphery.
It was first launched in periphery, I think.
Yes. So, and it continues to dominate peripheral angioplasty. So I guess people who are focused on peripheral angioplasty, they should certainly think of IVL because stents performance, I mean, like in coronary, we know the stent performance is outstanding, but long stents in the SFA, I think it has its own negatives. So I would probably feel if you can do without stent, something like IVL will work well. So IVL drug balloon probably might be a good combination.
Shravan, did you use IVL in peripheral anytime?
Only once, sir, along with a colleague, only once.
Okay. So bigger
It was a
size
highly calcified SFA. It was actually a physician. We used it on a physician where uncontrolled diabetic. The result was fantastic, sir.
You have 5 mm IVL. Huh? What size balloon, periphery?
5 mm is what we used for the SFA.
Okay.
Only once.
The vessel is bigger. Are there any tricks to use IVL? I mean, what is the biggest diameter IVL balloon comes for coronary? We have only 4. So in periphery, what are the balloon IVL balloon diameters?
They have even for the IO2LX segment now, sir. They launched even for the IO2LX segment. I haven't tried for that segment, but this was with the first generation balloon, like you said, quite some time back. It was a colleague's case, so I had joined him for the case almost a year back, sir.
People before doing TAVR, the stenosis is there, calcium is there, vessels to take it through femoral arteries. People are doing IVL balloons there, calcium cracking, then doing the TAVR through the same vessels. So all that thing is there. But always you need to be careful about doing it. In that algorithm which Madam showed, the calcium algorithm, that Kavita Madam?
Dr. Koita, Dr. Srinivas is asking you about the algorithm which you showed.
Yes, sir.
Yeah, that algorithm which you showed, basically, though the points and all are given, but it stands to common sense, is it not? It's basically the more thicker the calcium, more longer the calcium, more the difficult it is. No? So that is why the worst calciums are thicker calciums and longer calciums where you want to use IVL. You have used this rotational atherectomy plus IVL, no? There. Yeah. So basically, rotablation, we tend to use it if there is non-crossable, like you can't take any balloon there. So that's where you tend to use rotational atherectomy. We need to differentiate slightly from IVL there. So after you make a minimal passage, then you take NC balloon, then take IVL there. But if a patient can have IVL delivery, then you don't do rotablation, obviously, because anyway the balloon has gone. So where it is very critical calcified lesions where the balloon cannot go, that's where you tend to use rotational atherectomy. Now the latest version, the RotaPro, which is a lot of advancement over the previous rotation ablation. I thought they have innovated very much, sir. Hiramat sir, once I saw this orbital atherectomy, then I came to know they copied everything of orbital atherectomy, the rotational atherectomy. Everything is actually now we can advance through hand. So 80,000 to 1,20,000 and bar and all is the advantage of orbital atherectomy over rotational atherectomy. Only one bar of 1.25 and the variable speeds, and it's quite user friendly compared to rotational atherectomy. That is again for non-crossable, not where balloon cannot go. And it's more preferable for the proximal vessels and the bigger vessels. So that's what I just want to mention there. Rotational atherectomy is used for non-crossable calcific critical stenosis, whereas IVL is generally for more deeper calciums.
Recently, we have done few cases where we used rotablation first because the lesion was not crossable, and then we did IVL also.
Yeah, rotatripsy is called. Base people are calling because it produces a minimal lumen, but still there's a lot of deep calcium in imaging. Then you tend to take this and crack the deeper calcium. We tend to do OPN also in between, where the IVL everything is good but is expensive. So you always tend to use it in the end when everything doesn't work. That is the only challenge. So orbital atherectomy is somewhere in between the cost. But IVL, everything is good but costly, too much expensive therapy. That's the only problem. I think we had two good cases, sir. Any other comments, Hiramat sir? Otherwise...
Dr. Omkar, are there any more cases today?
No, sir. We have planned these two cases only, sir, for today.
All right. So we are coming to an end of today's discussion. I think we had two very important cases, two different scenarios, and I'm sure all of us learned a lot from these cases. Omkar, I think we need to key up people to get some of these difficult cases.
Yes, sir.
And every time we have a meeting like this, I look up my previous week's cases. I'm sure I keep saying that, oh, I wish I'd presented this. So I'm sure everybody has lots of very good cases, and we could sort of think and bring it together.
Yes.
Dr. Srinivas, you have any case ready to present? I mean, we have about 15-20 minutes, right?
9 o'clock, sir.
We stop?
No, it's up to you. I can.
Okay, do we have time or we stop?
No, it's not like that. So so it's not fixed time and also. So if it's not like that we have to close at this, but we have no other case at this point of time. So that's what
No, I will pull out one. Just give me a minute or so. Okay, Dr. Omkar, I don't think...
Yes, sir.
We have any... No, I don't think I have a case which can be pulled out immediately. Let me see. 1 minute. Oh.
Had I known, I would have taken out. I am also searching, but it will take a while.
One more, can you hear me? Initially, I had kept one case ready. So he's not picking up the phone. See, yeah, I mean, can show that case. We have time. Srinivas, your case ready? I mean,
I'm just pulling it out, sir. I'm just.
Dr. Onkar, I think we will.
Can I share the screen, Onkar?
Yes, sir. You can share the screens.
Shall I show one, sir? I got one small
Yes.
thing, LCX osteum, which I was thinking. Very happy. Just I wanted to show that once. I don't know whether it will play or not. At least I can show the still frame for the people. Are you able to see that?
Yes, sir.
This is a critical LCX osteum in an elderly lady who had ECG change infiltrate territory and then also had a calcific disease, if you appreciate that. And that's a LCX osteum. And this is the patient, initially they said for surgery, but surgeon was also not willing to operate because of age being very high. So that's where this is a video actually where we did a orbital atherectomy. Some of the video is downloading is taking time. But after doing this orbital atherectomy, then we shaved off and then we did a drug-eluting balloon, magic touch balloon. And afterwards, this is the result I got. So they almost, there's no residual. We did imaging also, good area we got. Finally, we left it. The patient came for follow-up after 2 weeks. She's doing fine. So worry was if you stent it, then probably LED would be compromised. We left it at this stage, sir. I thought this is a reasonably good result in an 80-year-old female.
No, not reasonably good. It's outstanding result.
Yeah, that's why we left it. We thought it's good result and the imaging also showed well. So,
but you know, the ostial lesions are always very difficult to achieve this kind of result.
Yeah.
So, I mean, this is one unique case, I would feel.
That's why I wanted to show, sir. Basically, this sort of tight lesion, whatever you do, it won't open up normally. But orbital atherectomy, we took the same 1.25 bar and did the dilatations with up to 120. Actually, therapy specialist was also there and it was giving a different type of sound once it is opened up. She was also making up with that. Then we did imaging and it had a reasonable area. And then afterwards, we just did a drug-eluting balloon and came out. This is the result. So this is another thing where I thought it will be interesting, where you can avoid stent and stent-like result. This is LCX osteum. This is done recently about 2 weeks back. I think
Can you show that case?
this I will show. Then I'll stop sharing if sir wants to show something.
But I think for circumflex, this result
Yes, we were happy. Elderly lady especially.
Outstanding. I mean, you always dream. I mean, even with stent, you don't get this kind of.
Yes. And then always something residual remains there. That's why I was very impressed with the orbital atherectomy, especially the osteal lesions, bigger vessels. I think it shaves off everything inside. And the advantage, they say, it shaves only the abnormal calcium material and the regular vessel will not be affected. At least the company claims that, and we're very happy. And they just did a drug-eluting balloon and came out.
And the people are down and they are
I think you got your slide, sir. Okay.
Yeah. So I'm showing you one case, and this is a RCA. It was considered easy, but turns out to be difficult, and that's why we are trying to gather opinion from you. So it had a proximal and a distal stent, and side branch to the distal stent pinched, but flows were preserved and hence was not stented in view of earlier difficulties in reaching the lesion location. So this is the scenario. The right coronary has two stents, and these are the diameters 2.5, 22, going towards PLV, and ostium was 3.5, 18. Then we have a 448 going from left main to mid LAD. Another, this is synergy, and another synergy going from LCX ostium to OM1. And this is done as mini crush with the earlier stent. So let's see the angios here. So patient has high LDL despite previous procedure. I'm very particular on this LDL figure. When patient comes for first follow-up, at the end of 3 months or 6 months, I insist that the LDL has to come down. Otherwise, they will pick up some lesion somewhere else, and they would come for a repeat procedure. So you can see here LAD disease right from the origin. OM also critical disease. Next OM also sizable vessel and showing a critical disease. So the plan was something like this. LAD long lesion, or LCX ostium to OM1, and from here to OM2. So that is what the plan was. So these are the diagnostics angiogram. LAD has a very long lesion, and RCA that way is relatively simple. So one focal ostial lesion and one lesion in the distality of RCA. So here you can see this is A is PD, and PLV branches into two good-sized branches, B and C. So I would probably feel that the stent here should start from the origin of PLV and go towards C branch, because mouth of B branch is not deceived, while mouth of C branch is deceived. So we are actually trying to get the wire. This was 2 into 15 NC balloon, I many times use these NC balloons because you can go very high pressure and the crossability is not as good as a regular balloon, but I think the end result they achieve is really. But on this case, we really struggled. After having done some dilatation, we were able to readjust the wire, the vessel where the stent should go, and we were very happy about this. So once the wire is in good location, we have a pre-dilatation balloon, the stent in good position. We didn't worry about come proximal to the origin of the side branch because the ostium of the side branch was deceased. And this is how we finally ended the stent going towards the biggest branch, covering probably all the lesions. This is a post-dilatation balloon, these two, and these are the final results. You can see here, this is how we started. The stent starts beyond the origin of this branch and covers in this direction. And you can see the flows going. And then the proximal lesion was quite an easy lesion. So this is what it was at the beginning of the procedure and after 2 stents. See, whenever you have multiple stents, multiple lesions in the side branch, so many times the worry is we would lose the side branches. But I think if we had not done the main branch stenting here, worrying about the side branch, I think we would have achieved this much of revascularization. So once we achieved this with 2 stents like this, we went to the left system. So here there is this wire in the OM1 and then the wire in the OM2. So plan is probably to do a mini crush here. So first stent towards OM2 and then a second stent will go from LCX to OM1, and that is how the mini crush is planned. So generally, when you deploy the stent, I deploy it around 6, sometimes at 8, but always bring back the same balloon, maybe 1 or 2 millimeters, and then go high on the balloon pressures to something like 14 or 16, as you can see here. So you have withdrawn the stent, so you are unlikely to have a dissection at the distal end. And this is quite important. Once you have good flows, no dissection at the distality, you can draw the side branch. At this stage, the LED is wired. Now, which wires to take is again important consideration, because so many times you withdraw a wire and need to reintroduce the same wire. So always my choice of wire, once the stent is deployed and you want to recross, is generally cross 100. And it's a slippery wire, but it crosses very easily. And you can park it wherever you want, the distal portion of the vessel. So at this stage, you can see good flows in the OM2. We are ready for a mini crush between LCX and LAD. So the bed is prepared. I would probably feel that these kind of ostial lesions, I think Dr. Srinivas showed a very good case where he has used IV. He used DEB, but I would probably feel that I would always use a cutting balloon on this kind of ostial circumflex lesion. So we are doing a mini crush between LCX OM1 stent with the OM2 stents, and we are having a balloon left main LAD to sort of flatten out the back end of the projecting stent. The stent balloon is up towards OM1. Then we use NC for post-dilatation. Then we wire the OM2. You can see a kiss between these two branches. And then you're getting ready to put a stent in left main to LAD. So here, the back end of the protruding stent is crushed with a bigger diameter balloon. You can see nice flows in both these OM1 and OM2 branches. So this is a mini crush between these two stents. And we are now getting ready to do a stent to left main LAD. Now, whenever you are doing a stent to left main LAD, I always like to get the stent position very nicely. I think you must sort of have a stent protruding out a little bit in the aorta, and that is the LAO cranial is a very good location to do that. Some people do this in epi-steep cranial also. Even that's a good position. And when you inflate the stent balloon, keep your Y connection open so that the stent guide catheter automatically slips back, or on purpose pull back the guide catheter so that the guide catheter and the back end of the stent are not hurting each other when the balloon is up. So this stent is deployed 4x48. Then you do a pot. Now, pot is very important because here you want to rewire the LCX, which has two important side branches, and then you can do a case. So pot, very important in this particular case. Then you are wiring the side branch. Generally, we like to take a hydrophilic wire when we want to address the side branch through the stent. Here we had some difficulty. The balloon was the non-compliant balloon was not going easily. So we put another wire, and over that we did the non-compliant balloon dilatation. And this is LAD and the circumflex balloon. So this is a case between LAD and LCX. And then there was a kiss done between OM1 and OM2. And this is close to the finality. You do a pot and take these kind of pictures. So to summarize, the OM2 stent was placed first. So this was a mini crush between LCX OM1 stent. The kiss was done towards the end. And then there was a mini crush between LCX stent and a long stent going from left main. So in this, the ostial position is very, very crucial. Never miss the ostial position. So for this, aleocordal is not generally the best view. You should take epicranial or an aleocranial view to get this position perfect. Pot, very important. Before you do a kiss, you do a pot, because wiring to the side branch is easy. And finally, towards the end, you again do a final pot to sort of even out, make the stent very circular, deeply embedded into the left main along its entire length. And this is how the final result is. The LCX, the OM1 at this stage appears not to flow properly. So we realized we probably have a dissection. So this was rewired and another stent was placed. So this is quite a headache, that you feel that you're almost through with the case and you realize that there is a dissection, a distality. And this is how balloon dilatation is done. Another synergy stent is placed. And so everything is done with high pressure infection towards the end, and this is the final result. So there is a mini crush between beyond OM1 stent going towards OM2. Then there was a mini crush between L6 ostium and left main LAD stent. Many would probably feel that culottes is probably a better technique under these settings. I would have done that. If I didn't have a lesion in the OM2, I would have done culottes. And this is the pre and post in aleocordal view and pre and post in aleocranial. So many people feel that the mini crush, which is sort of less taxing to the cardiologist, is not such a great idea. But I think under these kind of circumstances, it saves a lot of steps, saves a lot of contrast, and maybe you can finish the procedure quite early.
So great case, sir. How much time totally the case took, sir?
Well, it's not very recent, so I don't know, but I guess it must have taken long. Actually, what we had felt is the RCA, proximal stent and distal stent, shouldn't take long. But since these two side branches were quite big and quite important and diseased, I think this one took far longer time than what we had anticipated. So at this stage, we thought we would take a break and do the left system at a later date, but then one more procedure means one more cath lab installation. So I don't think the patient could afford this. So we did everything in one go. So it's about 19 to not very old, but no, it's 1 year old, sorry. But I think the end results were looking very good, and we were very happy.
Great case, sir. Actually, it needs a lot of patience also to do it. What we do sometimes is we stage it on the same number we give, so that procedure charge is avoided and stent charge disposables are done. If you are taking too long a time, sometimes operator comfort and this thing also should be taxing too much. Otherwise, two operators we always exchange with other vessel, that always keep telling. But a great result. So for you, the surgeon is not required. That sort of complexities with all the bifurcations also, only PCI, but complete revascularization is what is important, what you have shown. Another important point is where to take the stents, sir. Many of them would have a doubt. That point which you highlighted is very important. Where there is a disease in the branch vessel, I think stent should protrude there because the non-disease side branch may not occlude. But the disease side branch, if you can't, and obviously the size is also important. That's why you took it in spite of not being PDA, you took it into distal RCA because that had a lesion. And the size of the vessel also matters. That's how you finally could achieve good thing. And the final perfusion flow is good, then I think we can still go to the other vessel. But after doing the RCA, if there's some slow flow or some problem there, then that's where we tend to wait and see how the patient behaves and before we go on to the other vessels. But here, I think final outcome, you are satisfied. I think you went to left. And the other credibility to the latest generation stents is, in spite of the 2 layers of 2 mini crushes, still the stent goes distally. And you can plan the stent and place the stent into distal OM when there is point of bifurcation. That's a great tribute to the later generation stents. They go in spite of stents being done. But always, as you showed, no, distally we tend to tackle first. But unfortunately, you had some trouble which is noticed later, but still stent tracked so well, and you could place the distal stent so that flow is maintained well. Because such complex cases, if one place gets into thrombosis, everywhere could land into trouble. I think that excellent demonstration, great case, sir. Thank you for showing this.
Thank you. Okay, Dr. Omkar, I think time to call it a day.
Yes, sir.
That case, sir, in LCX, I just did not do only drug-eluting balloon, sir. We did a orbital atherectomy before. LCX osteum. Then we did a drug. After shaving out all the material, only drug-eluting balloon cannot produce so much of good result. What I showed, that LCX osteum.
No, it was outstanding. I mean,
orbital atherectomy worked quite well in that situation, I thought. Then drug-eluting balloon to prevent restenosis.
So at the end of orbital atherectomy itself, you are very satisfied.
Satisfied, but little irregularities were there. But once you did with a drug-eluting balloon, it became more smoother. That's all. But this case, what you shown, sir, I keep asking you this question again and again. So in today's era, is there any case where you electively send patients for surgery?
My surgeons also ask me the same thing, that when are we going to get a surgical reference? But I'm not that bad. I mean, I do quite aggressive stenting, but yes, I think, I mean, I still have about 5 or 8 surgical cases every month.
I think 2 CTOs, that's where we could send. I left main with 2 CTOs.
Yes.
I think that's where I think we tend to send to surgery, and the distal vessels are too bad where outflows are not good. Then we don't want to take chances. Those are some of the diffuse disease patients who would go for surgery. Thank you. Thank you, sir. Great case.
Okay, Dr. Omkar, I think maybe we can call it a day or call it a night, whatever.
Call it a night, sir. Thank you very much, sir. Initially, we planned to have 2 cases, but fortunately, we'll end up with having 4 cases. So that's the beauty of this program, sir, I see. And then the interest by you and the Srinivas Kumar, sir. Thank you very much. Thank you being a part of this session today. Thank you, Dr. Kavita Tyagi, being a part of this session. I also thank Dr. Shravan and our other moderator, Dr. Sujal Shah, for discussing interesting case studies. So we'll stop here and we will connect in the next month on a third Thursday to discuss 2 more interesting cases and a lot of discussion. Till then, have a nice time ahead. Thank you very much.
Thank you, Doctor.
Thank you. Can you become off live? I'll just 1 minute. I'll take.
Okay. So RX Events, can you stop the live telecast? And just confirm once you stop.
Recording stopped.
Sir, Hiramat sir, I was requesting Omkar also as what we discussed.